Hi, Kinesiology 4120. Today we're going to talk about rehabilitation, talk about working with medical staff, talk about how the strength and conditioning coach plays a role in the rehabilitation process for injured athletes. Okay, so let's start looking at the different rehabilitation specialists we're going to encounter when it comes to the return to play process for our injured athletes. The first one is the team physician. So in many cases with a damaging or traumatic musculoskeletal injury, the athlete will see a team physician. Team physician will then indicate to the athletic trainers what they need to do. The team physician is ahead of the athletic trainers. In some cases, especially with minor injuries, the athletic trainer may be the first and only first responder for the athlete to see. So athletic trainers are there. They may move over and say, hey, you need to go see the team physician, or they'll be able to diagnose and treat injuries on the spot, or especially if they're smaller injuries. Then during the rehabilitation process, or the kind of return to play process, athletic trainers may prescribe some different rehabilitation exercises, or they may direct the athlete to the physical therapist. So the team physical therapist will help with bringing the athlete back to kind of that baseline level where they're no longer injured, but they're not ready to completely play. That's where the strength and conditioning coach comes in. We're building this rebuilt or remodeled athlete from now in a kind of a better state than they were, but now we need to take them back to where they were before and try to push them a little bit further and get them to a new performance level like we are with the rest of our athletes. This is a kind of directive when it comes to the injury severity. Team physician may have orders that go all the way down to the strength and conditioning coach. Physical therapist may have things that come down. Athletic trainer may skip the physical therapist if it's a minor injury and only talk to the strength and conditioning coach. But the key here is communication. Communication between medical staff and the strength and conditioning coach, and medical staff and the sport coach, and strength and conditioning coach and the sport coach are key to developing long-term, sustainable, injury resilient athletes, and athletes that are injured, give them the best procedures, the best process, and the best treatment to get them back on the field, back to playing, back to their daily life. Okay. When this communication comes into play, the athletic trainer or the physical therapist or the physician will often give cues to what should be done and what shouldn't be done for the athlete. These are the indications and contraindications. Indications are things that you should do and can do, that things to do. So for example, we may have an athlete here with an injured shoulder, and the athletic trainer or the medical staff says that they can train their lower extremity, their trunk, and the contralateral side. So what they're telling you here in this indication is their injured arm or their injured limb, their injured shoulder, and anywhere distally is off limits. Do not do anything there, but you may train and you should train the contralateral shoulder, the contralateral side, their lower extremity, and their trunk. So now it's your job as a strength and conditioning coach to modify their program to allow them to get some form of adaptation without hindering their recovery process or re-injuring the athlete. Okay. With those indications, there will also be contraindications, or things not to do. These are the no-nos, do not do, stay away from. So for an example here is, say you have an athlete with an MCL sprain. Okay, so they injured their medial collateral ligament in their knee, and your medical staff says do not perform cutting, running, agility drills, or lower body training that involves the knee joint. This tells you things to avoid, things to stay away from. The sport coach will know this, so if they're doing any cutting or running in practice, this athlete will likely not be able to practice. And then you as a strength and conditioning coach, you know that if I can't do any lower body training that involves the knee joint, I may be able to train the calf or the ankle. I may be able to train the hip, the trunk, and the upper extremities, but I have to stay away from the knee joint. So this may need you, or may force you to get a little bit more creative in creating training plans or modifying training plans for an athlete with this type of injury. This happens throughout the year. Many athletes get injured, hurt themselves either acutely or through some kind of chronic overuse injury. It's our job as a strength and conditioning staff to work with the medical staff to develop the best plan for these athletes so that they can return to play, return to their sport, and continue on helping the team win or trying to help the team win. Okay, so let's go into some different injury types, some things to look out for. The major injury types that we're going to look at are things like the dislocation, a subluxation, sprains and strains in their different grades. We'll talk about contusions, microtraumas, and tendonitis. So these are the common injury types that you'll probably see as a strength and conditioning professional. Anything beyond this is likely something with a surgery or something like a concussion where we don't have as much of a role here because they will often not be able to see us when they have some kind of major traumatic injury or especially any kind of head injury. So let's get started through them. Okay, the dislocation is a disarticulation of the two joint surfaces. So this is where one joint has now become two separate bones that are no longer touching or no longer articulating with each other. It's often the distal bone that is displaced in the shoulder, often anterior and inferiorly. As one example, we get them at the hip, we can see them at the knee, we can see them at the patella, sometimes within the hand, the wrist. These dislocations are common in more contact sports, especially things like basketball, football, soccer, where we're hitting each other, where people are making contact. You'll see you're more likely to have a dislocation or other combat sports. With a dislocation, it will often require medical assistance to rearticulate the joints. It may often have ligament damage. So likely this athlete that has a dislocation, for example, shoulder dislocation, will likely not be able to train that limb or that shoulder for quite some time. And you will have to modify for quite some time. They're not going to return to play that quickly. A subluxation is similar to a dislocation. However, this disarticulation only happens for a short period of time and the bones rearticulate with themselves or those joint surfaces. So it's a partial displacement. Sometimes it may stay partially displaced, but often it moves out of place and then returns to its normal articulating surfaces. This often also comes with ligament damage. An athlete with a shoulder or any subluxation will often be out for a shorter period of time than a dislocation, but they will have to have some modifications and they will likely have different instability patterns after. Because of that structural damage to the ligaments, they'll often have to alter their training, or you may have to add some more regression-based activities to regain strength in the musculature around that joint. Okay, when we come to sprains, sprains happen to ligaments only. So a sprain is a trauma to a ligament. We have 3 different degrees. First degree is a partial tear. There's a little bit of instability. Often they can return to play within the month, within 3 to 6 weeks normally, or even shorter depending on where it is. But they will see some kind of instability or often some guarding in that point. We often see these at the ankle, often in more jumping sports. So basketball, volleyball, and football, you'll often see more of these ligament tears or first degree tears. Second degree tears are partial tears, which add to instability. This is a stretch and micro tear. They'll often be out for a longer period of time, the worse the degree of the sprain. And third degree is a full tear, so that ligament is ruptured. A third degree tear within the knee would be something like an ACL tear, is a sprain, a third degree sprain to the anterior cruciate ligament. So any kind of ligament damage like that, we'll see it laterally in the ankle. We'll sometimes see it in the hands and wrists. We'll sometimes see it in the shoulder and see it at the knee. This will often require surgery to return back to their ability to play. In some cases, ligament sprains that are third degree and full tears will maybe go without surgery if they don't plan to return to sport, but most of our athletes will return to sport and will go through a surgery and often a 9 to 12-month recovery process before they can play again. A little less severe in some cases are strains or tears to muscle fibers or the musculotendinous system. First-degree tears are partial tears. You'll have normally strong muscle activity. Your muscle will be okay, but it will be painful. It often causes excess fluid buildup, as excess inflammation. It's a partial tear, but you can still continue to play. It's often a shorter recovery process, especially because the muscle has a much larger blood supply compared to the ligaments. We'll see quicker return to play. It may be 1 or 2 weeks. But with that first-degree tear, it does put you at a higher risk for greater grades of strain if you're unable to regain muscle strength and coordination after the initial injury. Partial tears or second-degree tears will often exhibit weakness in the muscle, and it will be painful and weak because there are more tears within the muscle. This will often have a longer recovery process, over a month in most cases, and you'll have to regain muscular strength. They'll often be off of using that muscle group for quite a period of time, and regaining strength and regaining hypertrophy may be necessary in that injured muscle group because they've lost that activity. Grade 3 or third-degree strains are complete muscle tears. This will often be a very debilitating injury and may require surgery, especially if it's a worse full tear in a muscle, in a large muscle group. This also happens at the tendon, most likely at the musculotendinous junction or the bone insertion point. You won't see as many mid-tendon strains, but you will see ones at the insertion site. You'll see third-degree tears at the musculotendinous junction where the muscle becomes tendon. Because that's the weaker point in the system, it's more likely to fail, more likely to be injured. Those tears will often require surgery and a long recovery process. A little less injury or a less severe injury is a contusion. This is an accumulation of blood and fluid within a muscle or within some tissues of the body. We'll often see them in muscle. This is a fancy way of saying bruise. So it's a severe bruise. You'll often see it in major contact sports, especially things like football. If you're getting repeatedly hit in one point in your body and it causes inflammation, swelling, and bruising where you've broken blood vessels and now there's an accumulation of fluid, it's often going to limit some muscle movement. It's not going to be long-term debilitating unless it is recurring. In that case, you may see something like an ossification or where bone starts forming within the muscle. That's a worst case scenario. Often a contusion will recover within a week and may just limit some training within one session or a few modifications. When it comes to overuse injuries, these often come from microtraumas that are repeated over time. So repeated effort activities, so things like long distance running, long distance swimming, tennis, different baseball for throwers, especially pitchers. You'll see overuse injuries come with tiny traumas without adequate recovery. And without that adequate recovery, and you're continuing to stress that system, it may fail or it may become inflamed, swell, cause pain, and eventually cause major injury. This can happen to bone, this can happen to tendon. Bone overuse injuries are often stress fractures. Stress fractures come from repeated impacts in most cases. You'll see these in more long distance runners and sprinters where they're hitting the ground, or gymnasts where they're repeatedly making contact with some surface without adequate recovery. We need that recovery, and then it also may come with nutritional status. Nutritional status can help with reducing the risk of these overuse injuries with a adequately fueled and adequate nutrients in the diet. When it comes to tendons, tendinitis, and tendinopathy, tendinitis is a overuse condition at the tendon. It will cause swelling, inflammation, pain. We often see it in the knee, we see it in the elbow. Sometimes we do see it in the shoulder, not as often. But it may require a reduction in training volume in order to rebuild and allow for recovery. Some great ways to help with that rehabilitation process is often eccentric exercise, which allows more time under tension. It allows more exposure without having to have high intensity loads or high velocities, and can help rebuild that tendon tissue. So you'll often see eccentric training to help build tendon quality, especially after a tendinitis. So that may be what you're implementing as a strength and conditioning coach, or maybe prescribed from the medical staff. Okay, so because these tendinitis, we'll see it at the Achilles tendon too. When we have overuse, stretching without adequate recovery, because the tendon has such a low blood supply, if we have weak tissue, it's more likely to develop one of these overuse injuries. So that's where this general preparation within our training program comes into play. If we are doing adequate higher volume training with our athletes, helping build tissue quality through eccentric and hypertrophy-based exercises or modalities within those exercises, different exercise prescription can help reduce the risk of developing some of these conditions. Right? Now we're going to go into the tissue healing process. The initial event will cause inflammation. Inflammation is pain, swelling. The immune system is coming in and trying to fix what's going wrong. We'll often see kind of this fatiguing system after inflammation. Our body's not going to want to use that tissue or use that area right immediately after the injury. And we have a reduction in a repair, and we're trying to guard, we're trying not to injure it any more than it's already injured. Once we get into the repair phase, often this comes a few days after the initial injury. When inflammation has gone down, that's why it's very important to reduce the inflammation after an acute injury, so that we can begin the repair process. This is where we start to develop more collagen and start to put together the tissue again. This is kind of our immune system response, hormonal response to develop tissue after the injury. Similar to how we talked about with the hormone responses for muscle development after a training. This is similar repair process at an acute injury site. Last, we have the remodeling section. This is the last bit. This is where we start to align the collagen, we start to rebuild that tissue, and we can begin increasing tissue strength. We will likely, as strength and conditioning professionals, not see our athletes if they are in this inflammation or repair phase. They're mostly with the medical staff. It's this remodeling phase that we play a huge role in redeveloping the athlete. If we try to remodel or try to train the athlete when they're in an inflammation or repair state, we may cause further injury. So this is where those indications and contraindications from the medical staff will say, hey, don't do this because it may increase inflammation. If we increase inflammation, we increase the total time it's going to take for that athlete to recover from that injury. And we want to speed the recovery process as much as we can. If that means we don't see the athlete, that may be what we have to do. During that inflammation time, all you can really do is limit further damage. If this happens in the weight room, which we hope it doesn't, it shouldn't, it will often happen at practice or in a game or in a competition. This is the site of the injury. When it happens, we just want to stop further damage. If we can stop further damage, we can start working towards the repair phase sooner. During that repair phase, if we're seeing the athlete, we're trying to prevent atrophy. We're trying to not lose as much muscle mass, as much tendon quality as we can. We're trying to keep the athlete as close to their pre-injury state as possible without furthering their injury. We may have to be adding in lower stress. They may be guarding or have altered neuromuscular control. An athlete that is injured and recovering from an injury will have a fear of re-injury, even if it's just a subconscious fear. So putting them in situations where they can be successful and feel safe while still stressing them to an ability to continue to progress their skill and movement efficiency can help us in not delaying that process any further than it has to. We want to avoid any activities that may cause guarding, cause protecting. As coaches, we need to notice if our athlete is maybe shifting over to one side. Maybe they're not loading their limb that got hurt. Maybe they're changing their trunk position to make it easier on the injured side. We want to see that. We want to cue against that, because if they become, once they are remodeled, once they're back to their previous pre-injury self and now they are guarding, they have a higher risk for injury on the contralateral side, and they're not going to play as well or compete as well as they could if they are not afraid or not subconsciously avoiding those activities. Okay, now that we've gone through this recovery, repair, now we need to remodel. We need to bring them back to competition level. I like to think of the remodeling phase as the GPP, or the general preparation, the off-season, post-season area within your training program. Is similar to the remodeling of an injured athlete. We're trying to return them to their competition goal, and slowly move into more sport-related activities. We can manipulate their velocity, we can manipulate open and closed chain activities, and build physical and metabolic capacity for these athletes. Okay, so they're coming back from injury, maybe it's the middle of the season and they have lost their aerobic and anaerobic conditioning. We may need to give that to them as a stimulus in the middle of the season so that they can maybe play closer to where they were before. Maybe we manipulate open and closed chain activities. We know that closed chain activities where we have our feet or our body connected to the ground are more similar to sport-based activities. So moving from more open chain, more stability in 3 dimensions, to more closed chain, more sport-related activities. If we have often some instability, we may add in some open chain activities in order to cause a greater stabilization response, something like an open chain, like a dumbbell bench press compared to a push-up. The dumbbell bench press is open chain, and we're going to require more stabilization from the shoulder muscles to get that athlete to maybe trigger the muscles that were hurt before. So it's all specific to what they need, and getting them back to their pre-injury status, and then starting to develop them into a very competition-based or a higher level of performance. All right. Now we'll go through some key points of what we need to do as strength and conditioning staff. The first one is communicate with our medical and rehabilitation staff. We should be in constant communication every day, at least every week, every few days, talking about the injured athletes, talking about where we're going to modify our training program so that we are doing what's best for the athlete and for the team. Okay, the team wants to win, but we want to have healthy athletes also. Next, we want to progress the athlete based on indications from the rehab staff and those contraindications. So focus on what they can do. And if they can't do something, make sure they are not doing that, because we want to get them back as soon as possible. It may require us to force the athlete to be a little bit more patient. The athlete is not going to want to be regressed. They're not going to want to have to do lower intensity exercises, or they may think that they're better or more capable than they are. We need to go based on what the medical staff says. They know the athlete, they know the injury, they know the developmental process, they know the rehabilitation process. It's our job to facilitate that process. And last, continue to communicate with our medical and rehabilitation staff. More communication, stay on the same page. If we're not on the same page, we are doing something, but our athletic trainers say, oh, that's probably not a good idea. There's miscommunication there. That's where athletes get hurt, and that's where athletes don't recover as quickly. So we need to be in constant communication about those injured athletes and what is best for them. Right, now we'll go into some key points when it comes to training that athlete. Okay, so when we're training that injured athlete, avoid the injured area until we are allowed to. So those contraindications are king. If they say you cannot use their right elbow, None of your activities, even though you may be training the upper extremity today, they're not. Okay, that athlete is not doing it. No matter if they say they can or not, if the athletic trainers or the physical therapist or the physician or any of the medical staff say they cannot do this, they cannot perform that activity. And it's your job as a strength and conditioning coach to tell them, no, we're not doing this, and it's for your best interest. You need to be patient. We're going to move you on and progress you and get you back to where you were. Just trust us. Okay. You may need to use machines or more stable exercises, especially if there's lower extremity or back, lumbar or thoracic or cervical based injuries. Those injuries are often compromising to our stabilizing structures. So any kind of back injury, we want to avoid any kind of axial loading, especially if we have a bar, like a bar on top of our back, or any implements in our hands. We may not want to engage in those activities. It'll often be an indicator or a contraindication: no loading on the spine, or no flexion or extension or rotation activities at the spine. Watch out for those. You may have to modify using some machines or more stable exercises, and modify based on what they're able to do. We don't want to overstress these athletes' bodies. Okay, we're trying to cause stress. We're trying to cause adaptation as strength and conditioning professionals. But these athletes are also trying to recover from an injury. So that means they're not going to be able to recover as quickly from other stresses, especially if they're a student as well. They have other school stresses. They may have family stresses. We want to cause some stress, some stimulation, but they're not going to become maximally strong. They're not going to gain a lot of muscle mass. They're not going to gain a lot of conditioning in this recovery phase. We're trying to get them back, and we don't want to overstress them so that they slow their recovery. Be mindful also of their emotional changes. An athlete that is injured will now feel like they are less than or not a part of the team. We want to make sure that they feel included and are a part of the team and being productive and allowed to train hard. If they can't be practicing and all they can do is strength train, they're going to be with you as much as they can, because you give them that purpose and that training that they think is giving them the opportunity to be better and to get back with their team. So make sure they feel included, make sure they're still a part of the team. They're involved in drills and whatever modification you have to give in order to keep them safe and help their recovery, do so, but don't at the extent of keeping them away from the team, because they're already probably not able to practice. They're probably already on the sideline, and that's going to cause some negative emotional changes for the athlete. Be aware of them, notice them, and maybe want to bring those up to your medical staff if you see that they are in a more depressed state. Maybe they're more anxious. Maybe they're not enjoying training the way that they used to before they were injured. Maybe they're not enjoying being around the team. Maybe they feel left out. Make sure you're noticing these, you're cognizant of them, and you make an effort to keep them involved and let your medical staff know so that they can also address it on their end, or maybe address it with the sport coach. Because if we have an athlete that we want to come back, we want them to want to be there. We want them to feel like they're a part, contributing member of the team, so that when they are back, they can continue to contribute and they will give their best effort. All right, that's it today for our lecture on working with the medical staff, rehabilitating our athletes. Focus on those indications, contraindications. Go through your lab for week 12, which is a modification of your lab 11. So you're taking that training plan that you developed for one athlete, and now you are given an injury. Your injury is listed on Blackboard with the rest of lab 12. Take that injury into account and alter your program for your athlete based on that injury and based on the indications and contraindications given to you with that injury. If you have questions or concerns, or you want to meet with me, please do so. I'm very available. We'll set something up. Thank you very much for watching, and keep up the great work. All right, I'll see you all later.